Hi, I'm Dr. Sooj. I'm here with Dr. Brooke Vandermolen, the OBGYN Mum. Make sure you give her a follow on socials. This is something that we've planned for a little while, and I've even fielded some questions from you guys to ask. So we're going to go through some of these. But before we get started, just tell us a little bit about yourself.
Sure, my name's Dr. Brooke. I'm an obstetrics and gynecology doctor. I'm also the mum of 3 young kids. I talk on my platforms about everything to do with women's health, pregnancy, fertility, periods, sex, all the likes. So yeah, really happy to break down any taboos or questions that you have.
Wonderful. So we've got periods, pregnancy, contraception, HRT, menopause, and random.
Mm-hmm.
Random can be really random.
That's fine.
Which ones do you want to start with?
Go to periods.
Periods, right. What do you do if you don't get your period for over a year? Not pregnant and GPs aren't worried.
So the first thing to think about is, first of all, are you on any hormonal contraception? Because hormonal contraception is actually really normal to not have your period. So for example, if you have a Mirena, you may not get bleeds at all. Certain types of the pill that you take continuously. And I think it's often not explained that you won't get a bleed with those things. So first of all, are you on any hormonal contraception? If you're not, I would say it's not completely normal to not have any periods at all for a year, unless your doctors have already looked into it for you. So if you have not had any tests yet, you go to your doctor and talk about your health, any other symptoms that you might have, if you had periods in the past and then they've stopped completely, if you've gained or lost weight, those kind of things that you're thinking about. And then the doctor may do some further tests. So some causes why somebody might not have any periods for a while, a common reason is Polycystic Ovarian Syndrome. But I think often it's put down to that without any further tests being done. So what I would encourage is somebody saying, don't just say, oh, it must be PCOS because I had irregular periods before. We want to also check that the signals from the brain are working okay. So we'd also be checking those hormone levels, for example, and making sure that it is purely coming from the ovaries for this, where are they having periods?
It does. So in GP land, we have, generally we say, until you've not had a period for at least 3 months, we won't necessarily investigate because some people do just have irregular periods. But it's really good that you mentioned PCOS.
Mm-hmm.
PCOS, I think, is a bit of a misnomer.
So it's Polycystic Ovarian Syndrome. So you should have some cysts on the ovaries. So you also have some other factors. So we'll be looking also at your hormone levels, so specifically hormones like androgens, which are kind of typically known as the male hormones, or things like testosterone. Obviously, female women also have those hormones as well. So we don't use that term. But we'll be looking at the signs of raised androgens. So sometimes people who have PCOS also have irregular periods, but they also have excessive hair growth on their face, for example, or have problems with acne or difficulty losing weight. So those are some of the other symptoms. So you do need to have those symptoms as well as having muscle cysts of the ovaries and some changes in the blood tests for us to say, okay, this is actually looking like PCOS. Another thing, because I see a lot of adolescents as well, the term PCOS is thrown about very early on. Anyone comes to the GP, they've got some irregular periods, you've probably got, and they might have acne as well. So they might be 16 years old, irregular periods, got some acne, you've got PCOS. And for the rest of your life, I've got this label of PCOS. But actually, it's really common to have irregular period in the first few years after the period start. Really common to have acne as a teenager as well. So we usually say, actually, we don't diagnose PCOS in adolescence or until it's been 8 years from when you've been having periods. And that's really important. So if you started your period when you're at 14, actually, you shouldn't really be given a label of PCOS until you're about, 22, because it's very likely to be something else. Now, if you choose to have those symptoms when you're older, then yes, it may well be PCOS, and there is things that we can do to help to manage that condition. But we shouldn't just assume that everybody with irregular periods or whose periods stop altogether has PCOS. Another thing you should definitely think about doing is a pregnancy test. Obviously, there's usually other signs, but if you haven't had a period in a while, especially if you're sexually active, always be doing a pregnancy test roughly monthly until you get that period at least, and you just want to be ruling that out.
Oh, 100%. In terms of someone not having had a period for a year, there are so many other causes as well, because it could be you have a rapid weight loss over a short period of time. You could be approaching the menopause. There might be like primary ovarian insufficiency, and you might have early menopause. There are so many different things that sometimes getting too much information can be quite scary as well. What do you think the best ways would be to kind of manage that? Or particularly when a lot of people, as you said, come in thinking that they've got X or Y or Z, so PCOS or endometriosis or whatever. How do you think we can help to manage expectations in terms of treatments? Because the treatments aren't amazing for those anyway.
So the first thing I would say is if you think that you've got one of these conditions and you're going to see a doctor, say, I'm worried I have PCOS. I'm worried I have endometriosis. It focuses the consultation and that helps that doctor to actually explain whether they do or don't think you've got that. So rather than you walking away feeling dismissed because you have painful periods, they didn't mention endometriosis, you walk in and you say, I've got painful periods. I'm worried I've got endometriosis. And they have to prove to you why they're not good enough for it. And it almost put that kind of conversation out in the open so you can have that. So I think that's one thing we should all be doing. Talk about what we're worried about. And of course, like I say, it's overwhelming, it's scary, but I think, yes, a lot of these conditions can't be cured. There's so much we can do to manage them. We're knowing more all the time about them that I always think that knowledge is power. It's empowering to know about your body and to understand your body. So try not to see it as something that's scary. I mean, I'm never going to have kids or whatever else that you have read online, and focus on good quality information and talking to your doctor about your own situation, what your own concerns are.
I completely agree with that. Right, next question. What is the cause of shortness in menstrual cycle? Like before it was 5 days, but now it's 2 days. Is that because of lower estrogen or do analgesics affect? Is that affecting being pregnant?
So having short periods is never necessarily something that's of concern. We don't necessarily say, oh, it's too short, it's too long. But we do typically say that a period would last about 3 to 7 days, maybe 4 to 7 days, probably more normal. But if you're having shorter periods, I want to make sure that you are actually having periods. So we'd be doing some hormonal checks anyway. But if you're having a bleed at the same time each month, it doesn't have to last for any specific amount of time. The sign that you're ovulating isn't necessarily how long your period lasts. Other signs to your body that you're ovulating. For example, what's your cervical mucus like? Do you get any pains with ovulation? Some people use ovulation sticks. They're not hugely accurate, but they can give you an indication. The best indication that you're ovulating is actually having a regular period. It doesn't matter if it's 28 days, 26 days, 31 days, and then some variation month to month. If you are having approximately a period every month, you most likely are ovulating. If you're not trying to get pregnant at the moment, you don't need to worry about that. But if you are trying to get pregnant and it's been more than 6 months and you're having both short periods and they're very irregular, then you should go see a doctor.
Fair. And I think also if you're on the combined pill, it can make periods really short and light.
Yeah.
So if you're doing that and having a monthly bleed or even having a bleed every couple of months, that could be a cause for like the shorter periods, right?
Yeah, so I actually would say to someone, if they're on hormonal contraception, I wouldn't even use the term period for when they get their bleed each month. So they might get a monthly bleed, especially if you're on a pack that have a break. But that period or that bleed may very well be shorter than usual. So we actually call it a withdrawal bleed rather than a period, because the term period should be used to refer to spontaneous bleed, whereas you're inducing that bleed with the pill.
That's really good. I actually never thought of the terminology like that. I would love to know how periods can suddenly change and go from being regular to irregular and bleeding for weeks on end without any obvious reason. Nothing seen as abnormal in the womb or ovaries. This is really interesting because I remember even working in an emergency and when I've been working in OBGYN in the past, there are people who come in having a heavy period for 2-3 weeks and we treat them with essentially progesterone plus or minus tranexamic acids. Why do things like that happen? Because we've never really, from an emergency point of view, we don't ever understand what's caused that kind of bleed.
Well, I think the thing we have to realize is some people call period, your menstrual cycle, like a sick vital sign, your heart rate, your blood pressure. But actually, having a period, a normal period of months, have a vital sign. The sign that your body is kind of everything is in balance. I hate this term, your hormones are balanced, but it is a sign that everything's taking over as it should. And when other things affect that balance, then of course it will affect your period as well. That's why like a vital sign. If something changes to it, is to say, are things kind of off? So if you're suddenly much more stressed, if you have a recent infection, if you're traveling and you're jet lagged, if you had some vaccinations, any of those things can actually just disrupt those hormones, that natural pattern, and it can cause a temporary disruption. Also, you might have become pregnant without realizing it. So sometimes people have a pregnancy, the period is a few days late, and then they start to bleed. And if you were trying to get pregnant, you may not have thought to do a pregnancy test. You may have had what was typically known as a chemical pregnancy, and that can again disrupt the following cycles. So sometimes we don't really know, like you say, exactly what happened, but it is quite common to suddenly what was a typical regular pattern to become irregular for a while and then settle down again. And it's helpful. That's why, it's always good in a consultation to just ask someone, how have things been going for you in your life? Well, actually, I changed job, I split up from my partner, and I moved house. And although they may not put those things down to why their periods have changed, someone it's just fine that stress kind of your body is showing it for you, if that makes sense. So that's why I think it's helpful to understand. But again, that doesn't mean you can't have treatment for it. If you are having, a 2-month long period, you're going to get anemia, but we do need treatment to help you. And just telling you that you're stressed is not going to make you any less stressed.
It can be really challenging in general practice because stress isn't just a mental state, it's a physiological state. And people say that, oh, this has been me for the last however many years, but it's not something that suddenly one day you wake up and you're stressed. It's a cumulative effect over days, weeks, months, years. And what I found is that people don't want to really necessarily acknowledge that they have been stressed for a long period of time. And it can be really hard because we do investigate for a lot of things. But when we eventually settle down on, the most likely cause is that it's probably everything else that's going on in your day-to-day life that's impacting and leading to the symptoms that you're having, it can be quite hard for people to acknowledge and come to terms with that. How do you... Also, a lot of the time they don't want to hear it from a GP, they want to hear it from specialists. So do you find people are generally more receptive in secondary care?
To an extent, but that's why I always think it's helpful to say exactly what it is you're worried about, what you want. Because sometimes it might feel like the doctor has an agenda and the doctor is trying to dismiss your concerns or not taking... Because even still, someone might come to us and they say they're worried about endometriosis or want to have the surgery. We might say, well, you're having painful periods. It doesn't sound like, extreme enough to do a surgery yet. And we talk about hormonal options, they feel dismissed because we didn't give them the surgery that they came in wanting. That's why I think if you come in wanting something, say it out loud. But another situation where I find it's happened to lots of people coming up to try to get pregnant. And they've had regular periods their whole life, then they start trying to get pregnant, and suddenly periods completely, they go haywire. They're all different lengths, they're unpredictable. Every month they can be pregnant, they miss their period by a week. But actually then it comes and they're really frustrated, like, my periods are completely regular and now suddenly they're not clearly fixed. And obviously there is a lot of underlying stress that comes with trying to get pregnant. It's pressure in a relationship. You're also trying to fit it in around work and everything else. And so you don't really realize, again, how that stress is affecting your body. And what we say is, relax to fall pregnant. It's the most unhelpful thing to say. And again, can't be done. It's not a switch that you can flick on. And usually it's been a while building up to that point. It takes a while to settle back down again. So yeah, in terms of kind of how to negotiate that, I don't think there is any one best way. And I think that the most important thing is to say what you're looking for from your doctor. And sometimes, and I like to try to explain every test that might be done for that situation and why I may not be doing that test. Because it's one thing to say, look, your periods are irregular, we've done the blood test, they all look fine, we've done an ultrasound, it's fine. So I think it's a few months. But if you explain, some people in this situation might also do these additions. I'm not going to do them just yet because actually I think things are looking good for you and I think you should go ahead and try and get pregnant. And a bit of reassurance, that is often what that person's looking for, just an explanation.
I agree. I completely agree. I think that's really important to say. Just have that open dialogue. Let's go to a random one.
Okay.
Fibroids, symptoms and treatments, please.
Okay. Fibroids are benign growths in the lining of the womb. So they come as little kind of, depending on the size, then little like golf balls. They might be bigger, more like an orange. They might be even smaller, like a pea. Oh yes, they can be even the size of a melon. So
Have you seen them that?
Yes, I've seen them.
I've seen it. Probably that big. When I was
like a 50 decoys.
When I was assisting in C-sections, yeah, they're like that.
50 decoy, yeah.
Very satisfying, just scooping them out.
Yeah, exactly. So they not only can get really big, but they can also be really numerous. So you might have sort of 25, 30 or more in the same person. So there's a huge spectrum. So I would say, over 70% of white women and over 80% of black women have some fibroids in the uterus, but they might be those really tiny ones, but they may be very numerous. Now, black women tend to have more issues with heavy menstrual bleeding, and they particularly have heavy bleeding relating to fibroids. That is much more common. And another issue is that because it's been dismissed for so many years or normalized within certain cultures, people often didn't know that they could even get help for having fibroids, having heavy menstrual bleeding relating to fibroids. So one of the commonest symptoms that you have with fibroid is heavy periods. And especially if you have fibroids, your mum may well have had fibroids, your grandmother may have had fibroids. So everyone in your family around you also suffers with heavy periods. They won't tell you they're not that bad, they're not that heavy. But actually, when you were at school, you struggled to go to school, go through a lesson without having to leave and change your pads, for example, or you're in the middle of the night or flooding onto the bed. Those are signs of really heavy periods. So even if everyone around you has the same thing, that is probably excessive bleeding and may make you anemic. So it's really important, if you think you've got fibroids or you're struggling with heavy menstrual bleeding, to see a doctor. Often we can treat that heavy bleeding with even non-hormonal medications like tranexamic acid to reduce how much bleeding you're having, or hormonal medications. Or sometimes people do need surgery as well. And it doesn't always mean you have to have a hysterectomy. I think that's a common misconception. Everyone with fibroid then does hysterectomy. We can sometimes just remove the fibroids or do different types of surgery depending on the location, the size, and the number of the fibroids that you have.
And surely it would also depend on whether we're trying to preserve fertility.
Absolutely. So where you are on your journey will very much depend on which option you're going to try. Fibroids do tend to increase in size throughout your lifetime. So it doesn't tend to be a problem for people who've just started their period. So if you've got heavy periods and you're a teenager, for example, it probably isn't fibroids, but it is something that may come out later on, or may just be a problem through right around the time when you're trying to be pregnant. So that's when we do need to think carefully, is going in and doing a surgery to remove the fibroids, will that benefit you in getting pregnant? Or is it better to wait till you've completed your family, after you've had your children, then we think about what treatments we can do. Sometimes we can even do something called a uterine artery embolization, which means actually blocking the blood supply to those fibroids, which helps them to shrink. But we don't recommend having a procedure like that if you're still planning to be pregnant.
Are there any hormonal treatments that help the fibroids to shrink?
There are some treatments that help fibroids to shrink that tends to be temporary. So we use those in somebody in whom we're planning to maybe do surgery on a later time. So we tend to give them, because that might enable us, for example, instead of having to do an open operation, to help to do a keyhole, because we can shrink those fibroids, and then we could do a keyhole operation to remove the fibroids and be able to remove them through a smaller pore. But we wouldn't just give that medication to shrink the fibroids and that's it, because they just tend to grow back as soon as you
Fair enough. Right. I think this is a really good question. There are three that are similar. Why don't providers who fit IUDs in the UK offer appropriate pain relief for placements? I have fainted twice during one placement due to the pain. I feel it should be spoken about more. So I have assisted. I've been there when IUDs have been inserted. I've done it myself in theatre, which is a bit different. But there are lots of people that can tolerate it, and it's actually not painful for them. What has been your experience, and why do you think that the cervical blocks aren't given?
So when you're coming in to have a coil put in, so the actual procedure itself is the same as when you have a smear test. So you have a speculum placed into the vagina to help to visualize the cervix. So when we can see your cervix, we can see a little hole there that we basically try to introduce a small tube. So the actual process of having an IUD inserted isn't any more painful than a smear test necessarily. It might stay for a couple of seconds. That doesn't mean a smear test isn't uncomfortable or painful, because many find those are. You should never skip going to your smear test because you're worried about pain. We always say, come and let us talk to you about the options. And it's the same thing with having an IUD inserted. Some people, many people, tolerate having a coil inserted, don't barely notice it's got in. And for other people, it can be a really traumatic experience. And having it actually something pushed through your cervix can cause you to faint. It's actually kind of a specific reaction to the cervix. It's like a vagal response, yeah. So you can faint as a result of having something placed through the cervix. And I think if that's happened to you before, even more reason to have that conversation with your doctor and ask, what pain relief options can I have before having the coil inserted? I'd recommend everybody takes a couple of paracetamol before, maybe some paracetamol and some ibuprofen before coming in to have like an hour or so before having that coil fitted. That might be enough for you. We can also use a local anesthetic gel, so like a lidocaine gel, similar to when you put a catheter in. You can place that, wait for a few seconds, and then sort of 30 seconds to a minute to allow it to work a little bit, and then put the coil in through it. And again, there's only that may be enough. If that isn't enough, or you've had a previous difficult experience, then we might talk about the cervical block. But the thing is that also in itself, can be quite painful. So having a cervical block, which basically means having a needle go into the cervix, is probably more painful than the actual process of having oil put in. So it's not appropriate for everybody, but it's something you can definitely discuss. So for some people, it's just not even an option to have a coil put in when you're awake. And we do them for people when they're asleep. So we can do them under general anesthesia as well. It's not the procedure of choice, because having an anesthetic has its own risks, but you should basically just talk about what's right for you rather than us thinking about, for everybody. Should everybody have a cervical block? I think another thing that kind of make people want to avoid that procedure is if you suffer with vaginismus. So vaginismus is, again, a condition that's probably more common than we realise, but we just don't speak about it enough. So vaginismus is a mind-body reaction to a fear of penetration. So you might have had some traumatic experience to having penetration from sex. People who've had traumatic sexual experiences, even having a finger inserted can be painful, even having a tampon inserted can be painful. And what happens is you have this involuntary contraction of the pelvic floor that makes it like a brick wall. You can't even insert anything into the vagina. So if you suffer with vaginismus and then you need to either go to have a smear test or you need to have a coil insert, it's horrendous. And even the fear of that process itself worsens that pain. You have experienced a very true pain when someone tries to insert that. So that's a different thing as well, and needs its own kind of treatment and approach. And going in and doing a cervical block on anybody that has vaginismus, we can't even get near the cervix because their pelvic floor is so tight. It's not the best approach. So it's definitely better to have an individualized approach, which pain relief option is better for you.
Agreed. The next thing then is moving on to hysteroscopies, which again, I've seen them being done, assisted with them. They can be really painful, and I've seen some people just completely content with just paracetamol and or ibuprofen, and others have needed gas in air, the cervical block, and then some have then needed on a referral to have it done under GA. Yeah. Do you think it's similar to having the coils fitted?
Yeah, so a hysteroscopy is where we're putting a camera in through the cervix, through the neck of the womb, in order to look inside the womb. So we're getting a picture from inside the womb in order to look for things like fibroids, polyps, so someone's experiencing heavy menstrual bleeding, or if they've got very, very light periods, and we're looking for something like Ashland syndrome, where someone has adhesions that's kind of blocking the cavity of the uterus. So we might recommend a hysteroscopy for those kind of reasons. Or if someone is having postmenopausal bleeding, we're looking for a reason why the lining of the womb might be excessively thickened, for example. So if you've been told you need a hysteroscopy, usually the first port of call is to have that done under a kind of local anesthetic or with you awake, an outpatient hysteroscopy. So what that means is you come into the hospital, usually sometimes in the back of an outpatient clinic, and you have this procedure. So your uterus is filled up with some water, and we use the camera, place it through the neck of the womb to have a look. Now, having that procedure is similar to having a coil inserted, in the sense you're passing a scope through the neck of the womb. It can be painful, particularly if the doctor needs to use something to pull on your cervix in order to help make some traction to insert the hysteroscope in. If they are having to use a little pincer to hold the cervix, they should absolutely be giving you some pain relief, particularly to the neck of the womb. If not, then they may not be offering any additional pain relief other than some paracetamol ibuprofen before the procedure. Again, many people tolerate that very, very well. They don't need any extra pain relief. It's a 3 to 4 minute procedure, and that's that. If you might need some treatment during that procedure, so we're going to actually remove your polyp with the hysteroscope, we're going to remove a bit of the thyroid, or we're going to take a biopsy at the lining of the womb. In that situation, you may again benefit from slightly more pain relief, so a cervical block, because we've been moving that hysteroscope in and out. So for many people, no additional pain relief is needed. But if you've had it before you found it really painful, or you're really worried about pain, talk to your doctor and they can see what they can offer you. And if you just feel uncomfortable with the idea entirely, then yes, going for the procedure under general anesthetic is also an option.
Perfect. Ashland syndrome. You mentioned Ashland syndrome. This is something that I only know in exams. Mm-hmm. So tell me, now that you mentioned it, it makes me think that I should be looking out for it a lot more than I really am.
So Ashland syndrome is where you get intrauterine adhesions that obliterate the cavity. So what happens is usually it's because somebody's come in, for example, with a miscarriage, and they have a surgical management of miscarriage, or they have a surgical termination of pregnancy, or any other procedure where there's a bit of a scraping to the lining of the womb. And what happens is that there's kind of an overzealous attempt at healing by the uterus, and it causes this scarring. And if that means the lining of the womb can't grow and shed properly. You get very, very light or no periods at all. But the main issue is because you have these cavities, the cavity is obliterated. There's no cavity to be seen. There's nowhere for a pregnancy to implant and to grow. So we commonly find Asherman syndrome where someone is trying for a pregnancy, trying to conceive, they're not experiencing regular periods. And so we either look, first of all, with a scan, with an ultrasound scan, or we look with a hysteroscope. We just can't even see a cavity, can't see an opening inside that uterus. It's a difficult one to treat because, as you know, when you cut any kind of adhesions anywhere in the body, what happens? They grow back, and they usually grow back thicker. So that's the difficulty with treating the adhesions of Asherman syndrome.
Mm-hmm.
So sometimes we try and we may cut back on some of the adhesions. We may place a coil to try to reduce the chance that those adhesions grow back. We tell that person either to straight away try to get pregnant or to go straight for IVF to try to kind of reduce the time period in which those adhesions can grow back. Sometimes it does keep happening, and those people then end up needing to go for surrogacy, for example, if they want to conceive. It's one of those conditions, it's still very rare that it happens, but when it does happen, it has such a significant impact that it's important to be aware of.
Yeah, that makes sense. So this is now about HRT and menopause. My level of testosterone is very low, and I've been referred. What are the symptoms of this? Having low testosterone. I have some, especially no sex drive, like no sex drive.
So this is a female patient.
Female patient, yeah.
So if you have low testosterone, you don't actually really know what that means. Now, the reason I say that is because it's good that we're now even checking testosterone in women, because traditionally it was thought it was the male hormone, but we do know that women have testosterone as well, but we still don't fully know what is the normal level of testosterone. We know what's an abnormal, excessively high level of testosterone, but we still don't fully understand what impact that testosterone has on somebody. We know that, like estrogen declines when you go through the menopause, we know that there is a decline also in the production of testosterone. But the most important thing is actually that if you're experiencing symptoms, that you speak to your doctor and they may arrange those tests. So it's important to kind of interpret it in your overall health picture. So where are you? Have you gone through the menopause? Are you experiencing symptoms? As the symptoms are low testosterone, we don't really know. But then people typically test testosterone because they are getting a low sex drive, for example. But we also know that having a low sex drive is very common, and there's a lot of things that impact on sex drive. For example, where are you in your life? How's your sleep level? How is your relationship? How are your concerns about your body? All those other things can impact on your kind of libido rather than just treating it with hormones. And I would tend, if somebody has got symptoms like vaginal dryness as well as a low libido, think, okay, do you have a low estrogen level first? We'll treat and replace those. But we know these days that people like to be prescribed testosterone, especially if they are having HRT for the menopause. But the jury is still out as to how much of an impact that has. Some people find they tried HRT with this kind of typical estrogen and progesterone replacement. It hasn't helped their sex drive, so they go for something they are thought to be prescribed testosterone. They try it for a while and they come back and they say, I don't feel any different.
Interesting.
So it's something that I think can be worth considering. It doesn't necessarily require a low level of testosterone in order for us to sort of replace it, but it's also not to hold out that that's going to cure everything.
I think I find that as well in general practice, because I'm very comfortable with prescribing HRT, but there are certain people out there who say that you just need to have more and more and more estrogen, and that's not true.
Mm-hmm.
There is not that much evidence that going up on the estrogen will also improve the symptoms of the menopause. But people still want to do it. And actually, I found, so my best consultations have come when the patient has been really receptive to talking about the other things that are going on in their life. Once I explained that there isn't a huge amount of evidence for just going up on the estrogen. And I think that some doctors will just go on because it's an easy consult then. Yeah, we'll just go on estrogen, that's fine. But like I had a patient who's their child was recently imprisoned. And as soon as we started talking about that, it unlocked this whole other element of the consultation, which then took us down a more mental health route rather than I'm just going to give you hormones for the sake of giving you hormones.
Yeah, we kind of got two sides of the same coin, don't we?
Yeah.
Because you've got on one hand all these people that come in, they're approaching the menopause, they've got brain fog, that they're finding it really difficult to concentrate, they're sleeping badly, and everyone says, oh, you've got depression, you've got anxiety, and they're dismissed and they're not offered HRT. And then you've got the other side of the coin where you've got somebody, and they have experienced 1 or 2 hot flashes, they will give them straight away HRT, and then these other things are going on in their life, and everyone just puts everything down to the menopause. And I think, we've got different extremes to think about. But if someone's coming in because they're specifically worried about their sex drive or vaginal dryness and things like that relating to sex and the menopause, I think it's important to think, what HRT have you already tried? What other symptoms do you have of estrogen deficiency? Because if actually you don't have any hot flashes, you don't have any vaginal dryness, you don't have it, everything else is fine, it's just sex drive that's bothering you, I'd be thinking, is this estrogen deficiency? Or is there something else that's going on as well? I think specifically for symptoms relating to sex, we should always be thinking about vaginal estrogen, not just giving systemic estrogen. So specifically focusing the estrogen in the vagina can really help to improve symptoms. And if you've tried those things, often testosterone can be tried, but may not make a difference.
That leads us on to our next question perfectly, which is, how safe is estrogen gel for someone who's had a DVT and PE, stage 3 endometrial cancer, and ovarian cancer? So if they're talking about estrogen gel, HRT, then not safe at all. But if they're talking about, let's say, estrogen pessaries and estrogen creams for vaginal dryness and urogenital atrophy, is it a contraindication? Are we allowed to use it?
So let's think about HRT and the risks of HRT and who it's not suitable for. So the main things we need to be thinking about if we're going to use something like HRT, the risks are blood clots, so DVTs and PEs. Those are important. They're higher risks with oral HRT than having it transdermally, so having it, for example, in patches. So risks of blood clots, risks of cancers, as you've mentioned, so the estrogen can specifically give you a risk of endometrial breast cancer. So those are important things to be aware of. And we always want to be talking openly about the risks of HRT with anyone who wants to have it, because yes, we can definitely prescribe it for you, but we've got to be thinking, what are the drawbacks of giving it to you? So if you have specifically experienced some of those, we may not be jumping in with systemic HRT, but it doesn't mean that you can benefit from, for example, specific feminine vaginal estrogen. So we're going to be thinking, can you have a vaginal estrogen? So for example, you have a family history of breast cancer, you haven't had it yourself, and you're worried about having systemic estrogen, then in that situation, just going for a specific vaginal estrogen, if vaginal symptoms are your problem, may very well be an option for you. But if you've had a number of different cancers and you've had a number of different cancers personally, particularly any estrogen-driven cancers, we would be much more hesitant. And I would say it's important to think carefully before taking any forms of replacement estrogen, speaking about your own situation, your own cancer with your doctors about whether or not they recommend it. If, for example, having estrogen is not an option for you, there are other options. So if you're struggling with hot flashes, then sometimes things like SSRIs, medications that are given for depression, are a great option. If vaginal dryness is your problem, then sometimes vaginal moisturizers and lubricants can be really helpful. So it's not saying you can't have any treatment, but sometimes we need to think, right, this is not the best thing for you because we don't want to further increase your risk of having cancer or having a recurrence of your cancer, but instead we're still going to offer you other treatment.
Yeah, I completely agree. And I think paroxetine is one of the ones that's been licensed. There are others not necessarily licensed in the UK, but are licensed to treat the vasomotor, the hot flashes and night sweats in the US and other countries. So I think it's only a matter of time before they start getting incorporated into not even the NICE guidelines, but in the British Menopause Society's guidelines, which actually where I get a lot of my information from.
Yeah, it's a really good place, actually, a really good resource. And especially if it's something that you're going through, then do look up the guidelines. You don't have to be a medical professional to read them. It could be, again, a really empowering thing that you take with you to your consultation and say, look, I know that there are alternative treatments for the menopause. I've read that these things are recommended because, we can suggest that acupuncture can be effective and it's written in the guidelines. So it's not to say that just because something isn't a mainstream medication that we can't offer something.
Exactly. Let's move on to pregnancy. So can we have information on using SSRIs and NSAIDs during pregnancy, please? So SSRIs are cytostatic depressants, NSAIDs would be ibuprofen, naproxen. What are the considerations for continued usage please don't use ibuprofen and naproxen or aspirin or anything like that during pregnancy. Aspirin is a bit of a contentious one, but there are specific indications which gynecologists can prescribe it for. But definitely no ibuprofen or naproxen ever during pregnancy.
I'm kind of caveat.
Is that wrong?
Well, I would.
Not from us.
Okay.
I can take it.
Exactly. I would say, first of all, there's a really good resource to look up. It's called BUMS, which is a really good way to look up medications in pregnancy and whether they're safe or not. Now, yes, the advice is to not take NSAIDs in pregnancy. However, there is a window. So we don't want to use them early, like in the first trimester, and we don't want to use them at the point when, because what we're worried about is that there's certain valves in the heart and developing, and we don't want to cause a premature closure of one of those valves. So we don't want to give them particularly in the third trimester and later on in pregnancy, but potentially in the middle of pregnancy, actually you can take medications like neurophytic, like ibuprofen. If you've tried other forms of painkillers that haven't worked for you, then they can be used at certain times. The other thing you mentioned there was aspirin. So aspirin is an anti-inflammatory medication, but we do now recommend aspirin for a lot of people in different situations. So you might be recommended to take aspirin because you experienced recurrent miscarriage. You might be recommended to take aspirin because you have had in the past blood pressure problems in pregnancy, or you're at risk of getting blood pressure problems like preeclampsia in pregnancy. So it's used as a preventative measure. So yeah, they can be used and they are recommended in those situations to reduce your risk of getting preeclampsia, for example. Or the other thing you said, yeah. So SSRI is a group of medications. In general, when it comes to any medication in pregnancy, say if you can come off a medication, then do. But actually, we know that, for example, in medications relating to your mental health, if you come off everything because you're planning to get pregnant, or you just found out you're pregnant, that actually that can cause a worsening of those symptoms of your mental health in a way that is worse than continuing to take those SSRI medications. So some of those medications are associated with some very, very small additional risks to your pregnancy, but it's important to kind of think about your specific mental health issues and your specific medication with your doctor, whether they recommend that you do come off it completely. If you concede and you're already taking this, do not panic, because it is better not to suddenly stop taking any medication. Speak to your doctor and work out, because many people do successfully take their SSRI throughout their pregnancy, because the risk for them of having a severe worsening of their depression in pregnancy, which can cause, suicidal thoughts, self-harm, it's way worse to come off those medications that have been helping them than to actually continue them.
Yeah, I agree. And I remember from Revive for Exam and things like that, but sertraline is one of the safest ones because it's one of the oldest ones.
Yes.
Would you recommend, I don't know if this comes under you or more perinatal stuff, but would you recommend that people would switch over to a different antidepressant, for example, if they're on a newer generation of fluoxetine or something else like that?
So this is one of the good reasons why I would say if someone's saying, oh, I'm thinking about getting pregnant in the next year, should I do anything? So we'd say take folic acid for 3 months before you get pregnant. But also, if you are taking any kind of regular medications, go to your GP. And that's because, yes, we do sometimes recommend switching or stopping them completely. But remember, you know this better than I do, that any medications for your mental health, they take a long time to build up in your system, and they take a long time to wash out of your system as well. But getting to an effective level of a different medication can take some time. Mm-hmm. And so we don't want to be making any sudden changes, 2 weeks before you fall pregnant, because it's not going to help your mental health conditions, and it's not necessarily going to wash out to help baby.
Mm-hmm. So
I would say if you're thinking about getting pregnant, go and see your doctor with some time to spare, with 6 months to spare or a year. Make a plan. Think about, okay, I think I could come off these medications now. I'd like to wean down over a process of 6 months. Say, great idea. Or we'd say, okay, you're thinking about getting pregnant. You've already stopped all your contraception. You may be pregnant already. Let's not make any sudden changes now, and let's see how things go in the first few months of pregnancy.
Also, let's say you are 40 and you have high blood pressure. Your first line treatment at 40 would be an ACE inhibitor, which is contraindicated in pregnancy.
Yeah.
So it's a really good idea to have a chat with your GP, because there is that little interest. You can always switch over to something else, which would be safer to take during pregnancy.
Yeah, exactly. So there's lots of different options. And you also might look up something and it says, oh, don't take this in pregnancy, but actually we say, no, that's fine, carry on. So it's a good reason to say, go and speak to them about the medications that you're on. If you have epilepsy, if you have any neurological conditions, some of those medications may not be appropriate to conceive on. Rheumatology conditions, so if you're taking anything for arthritis, or because you have a bowel condition like inflammatory bowel disease, it's better to get on top of your symptoms before you fall pregnant, and it's also better to consider those medications carefully, and we can make changes.
Perfect. Okay, so there are some things that really scare me as a GP, particularly when someone is pregnant and they're coming in with lower abdominal pain, because my mind always jumps to the worst case scenarios. And something like placental abruption, they may not have bleeding, and they might be systemically well. What are your recommendations for GPs out there, patients who might be having lower tummy pain, particularly as they pass 20-24 weeks?
So placental abruption, which you mentioned there. So placental abruption happens when the placenta itself starts to detach from the wall of the uterus prematurely. So obviously what should happen is you give birth to your baby, and then the placenta separates from the wall, and then it comes out, and it's great way to stop the bleeding, because once the placenta is out, the uterus can contract and you stop having bleeding. If the placenta starts to come away from the wall of the uterus before the baby is born, and before obviously it's an appropriate time for the uterus to contract, what can actually happen is behind the placenta you can start to have bleeding, because those blood vessels that supply the placenta, there's nothing to stop them from bleeding, because the uterus can't contract and stop and tie off those vessels. So you start to have bleeding behind the placenta. And because it's a long way, there's a baby in the way between there and the vagina, for example, you may not see any bleeding. So if someone has some sudden onset abdominal pain, because that bleeding can cause them severe pain, or they start to faint, that can be a sign of concealed bleeding, concealed hemorrhage, a sign of placental abruption. And another really, really, really important sign that we don't want to miss of placental abruption is reduced fetal movements, because the baby there is uniquely sensitive. They need that placenta to keep supplying them with oxygen. So if there's a disruption to the flow of blood to their placenta, that can be shown as reduced movements. Baby's not moving like they want. It's the reason we always say don't sit on it. If you are worried that baby is not moving well, don't sit at home thinking, oh, is baby moving? Just come in and get checked out. Because the first thing we do when you come into the hospital, we put you onto the CCG machine. And that CCG machine, if there is a placental abruption, will show us straight away that there is something wrong with the baby.
I didn't know that. Okay. Is that because of the reduced movements?
Because the reduced movements, there'll be reduced blood flow to the baby, and it will show us, it may show deceleration, or it may show that the baby's heart rate has got really, really fast, because they're adapting to the fact that they're at lower oxygen levels. So whatever it is, you don't need to worry about it. What you as a GP or you as a pregnant person need to be doing is just come into the hospital, say, I've got some tummy pain and I don't think the baby's been moving so well. And we would then be looking for a placental abruption. And the treatment, if we're worried that someone has a placental abruption because the baby's not moving, or because we're worried, or we see it on scan, sometimes we can see that bleeding on scan, if you do an emergency cesarean section. It's one of those really scary situations where we all move as fast as we can. But it's important to know we're doing that for a reason. We're moving as fast as we can, because we're trying to keep you and your baby safe. Sometimes there's not time to fully explain exactly why, and you do kind of just have to trust the medical team around you. And it's scary, but it's there to look after you and the baby.
Yeah, it must be terrifying, because I remember when I was in gynae, and when that emergency alarm goes off, and then and before you've just got, let's say, the lady who's pregnant, the partner or the birthing partner, and the midwife, and then suddenly that room fills with about 10 different people. It must be terrifying. And in that moment, when you've got the specialist doctors doing their checks and then saying, okay, right, it's a Cat 1 or Cat 2 section, it's like there isn't that much time to explain things to the people involved. One thing that I saw that was really good at one of the hospitals where I worked was that they started introducing duty of candidate the day after any kind of emergency C-section, so that you can go through the notes and explain every single step to the parents. Yeah. And I think personally that's probably very helpful, but there must still be a lot of unknowns and things that, like guilt, that why has my pregnancy ended in this way?
Well, with the best antenatal class in the world, you can't really cover these types of situations. And it's where we have a difficult scenario working on a labour ward where, you know, we have a certain agenda. It's not agenda, obviously everyone's agenda is to say, keep your baby safe, keep the mom safe, get the baby delivered in a good condition. But it's different to maybe what the expectations that the parents have come in with. They've gone to an antenatal class, they've been told about, you know, this many contractions, you'll be this many centimetres dilated, and then this is the time, and then you'll push the baby out. And suddenly everything is wildly different than what they were expecting. And so not only are you telling someone that I think your baby is in danger, I think your life is in danger, I need to take you in for a major abdominal surgery in the next 2 minutes. And they've got all these certain expectations of what happens to this lovely birth experience that I was supposed to have. And, you know, is it something that I've done? What is going to happen to me and my baby? You know, this isn't fair. My other friends had this lovely, beautiful water birth vaginal delivery. And why am I in this situation? So it's so many things going on in that room at that same time. And you're trying to explain kind of a consent process. This is why I think, you know, when we try and tell someone the risks and benefits of a C-section in the 2 minutes before we need to perform it, we're not going to consent. No. You are the person that's there. You're not fully understanding or be given an opportunity to take in, you know, what is potentially going on. So whenever I give any antenatal classes, and I did for a long time, I did antenatal classes, and I sometimes do one-on-one antenatal classes. Whenever I say to someone, what do you want to talk about in your antenatal classes? And they say, oh, I want to talk about vaginal birth, I want to talk about labour, I want to talk about, you know, delivering my placenta. And I say, okay, so, and we'll also cover C-section, instrumental births. Yeah. And they say, I don't need to do this for that part of the classes. And I say, you know, if you want me to cover vaginal birth with you, then I want to cover these things with you. And I hope they don't happen to you if that's not part of the plan, but we don't know how things are going to go. And what I want for you is what you want for your health. I want a straightforward vaginal birth with no intervention. You know, as an obstetrician, I don't want to go in any room and do an instrumental birth or assisted delivery of birth with an instrument. Sometimes that is medically necessary in order to bring your baby into the world in the safest way, in the best condition. So it's really helpful before you give birth for you to be thinking about, what is my plan B? So I say, have a birth plan. Definitely have a birth plan. But on your birth plan, you should have a plan A and plan B. And if you've even thought about what might happen if someone might suggest a C-section to you, you'll have thought about those risks already. You'll have thought about how you might feel in that moment. So that means that if you do have an abruption and things are moving very quickly, it may not be how you wanted it to go. It may not be giving you enough time to process things, but you've already started that process a little bit earlier.
There's always an element of understanding.
Yeah, exactly.
That moves us really nicely on to home birth. Mm-hmm. What are your thoughts? Because I've got a friend who they had their first baby in hospital. They found it very traumatic. Their second baby, they did it as a home birth, and thankfully everything went smoothly. And they said that they would never have been able to do it again in a hospital, and also childcare arrangements would have been very, very difficult. I have spoken with obstetrics consultants who have, with all of their wealth of experience, would say no to a home birth, because if something goes wrong, something goes wrong.
So
what would be your thoughts?
As an obstetrician, and I've got a 5-month-old, my third baby, so I've given birth vaginally 3 times. And actually, with my third, I even considered having a home birth. So that's probably something you don't hear a lot of obstetricians say. In the end, I ended up with a hospital birth, planned hospital birth. But I would say if someone wants to have a home birth, we can absolutely facilitate that, and it can be a safe, empowering, enjoyable experience. And there was a place of birth study, I can't remember the exact name of it, but there was a study recently that showed if it's not your first baby, that giving birth at home or in a midwife-led unit is as safe as giving birth on a baby. So there is evidence to say that home birth can absolutely be safe. And my but is, it's got to be the right patient selection. So, and I completely understand that if you've had a traumatic birth, that your decision might be, I want to have a home birth next time. But actually, if you had a traumatic and difficult birth where you lost a lot of blood, for you, a home birth may not be appropriate the next time. So I don't think the right patient group, if someone had an uncomplicated first birth, it didn't have any complications, and they're having a low risk pregnancy for the second time, then if it's not your first baby, having a home birth is as good, as safe as having a birth in a labour ward. You may be less likely to have intervention, like having an instrumental birth, having a C-section. So it can absolutely be a safe and empowering way to give birth. But if you have hemorrhage, if you've got blood clotting problems, if you've got any concerns about the baby, whether you need additional monitoring,
Or
then
try and steer for a DBAC.
yes, if you had a cesarean section in the past, it would not be a safe place for you. And I understand why people might want to push for a home birth in those scenarios, but I want you to really sit and think about what you don't want to think about, which is what happens if things don't go to plan. Yes, we can think about if things go to plan, that's great. But what if things don't go to plan? What if labour starts and then stops? What if your movements of the baby is not quite as good as they were? What if the baby is born and needs resuscitation at birth and there isn't anyone there? Of course, midwives can give immediate first aid to the baby, but if they need that additional level of support, that they don't have an incubator there, they don't have a pediatric team, they don't have an anaesthetic team. If you collapse, if you lose so much blood, we don't have access to blood transfusions. So in the right people who are unlikely to need those additional interventions, then yes, it can be absolutely a great and safe way to give birth. But if you are likely to need interventions, you can potentially be 30 minutes, 45 minutes away from those life-saving interventions. And it can be the difference between life and death for babies and for mothers as well, depending on, what happens there. So not a scaremonger, because I'm pro midwife-led unit and pro home births, as long as the support is there. I'm not pro free birth. I'm sorry. And I know that some people find that they come in, free birth is literally giving birth without any support. Okay. And I think that often comes where the relationship is broken down. People have had difficulty. They don't really want to listen to by their medical team. The hospital couldn't offer them, midwives to support their birth at home. So they say, fine, I'll just give birth without anyone. And I understand that in that situation, we've made ourselves like the enemy. We haven't been able to facilitate their choices. But what you are doing there is taking kind of those risks and all those things that we can put into place to look after babies and mothers, and you're kind of doing it without those things, and that's potentially risky. And how would you feel again if things didn't go to plan? For the rest of your life, you're dealing with those consequences. So labour wards are a fantastic safe place to get there. Not always the safest place to get there. I'm sure people will jump on and say, when I had this traumatic experience on a labour ward, it isn't all hunky-dory, and I agree, it's not.
It's not hunky-dory, but it will be traumatic, but it will be safer knowing that you've got all hands on deck. I remember when I was working as a pediatrics and working in the neonatal ICU, I was the one that was the peds that would be getting to when there was a high-risk delivery or whatever. Even in cases where it's a low-risk pregnancy, low-risk birth, once the baby comes out, if there's any concerns, we would be there within a minute.
Yeah.
Because we were next to the labour ward.
And I think that's the thing that swung it for me in the end. Because so I had a very fast first birth, actually, which is quite unexpected. Baby was born within about 45 minutes. So 3 centimeters to giving birth within 45 minutes. It was quite traumatic to me, actually, I have to say. Now, I know we talk about trauma being, it's complicated, fully dilated cesarean sections, and it made me realize that even having a straightforward vaginal birth can be traumatic because you don't have any sense of control over yourself. You don't have any kind of dignity. You can't have access to pain relief that you wanted, and all of that. So I found that experience painful and quite traumatic. And when it came to the next time, I was like, well, if my birth is going to happen so quickly, then maybe I would be better off and have more control if I give birth at home, actually, in that environment, and don't have to rush. Don't worry about giving birth in a car or in a triage in front of people. And actually, maybe that'd be a better experience. And in the end, for me, I thought, if I can get to a hospital, if I can have access to the pediatric teams, the anaesthetic teams, if needed, I just felt more comfortable there. But I guess also for me, labour ward is a comfortable environment. Funnily enough, my second birth didn't happen as quickly. And my third birth was also quite quick, but I had both times actually managed to get an epidural, which I wanted. So, you don't know how your birth is going to go ultimately. And even I, as an obstetrician, how many births I've seen, I had no idea how my own births were going to go.
So we can always catastrophize quite easily. You have the experience to think about the worst, but then also reason yourself out of the worst thoughts. Whereas even me, as a doctor, the thing that I know really well, I can get scared about something and reason myself out. But there's so much where I don't even have the knowledge to, okay, well, this is why it's not the worst case scenario. You mentioned giving birth in the car. So a person from my school, their wife, they were convinced they were going to later. There is their second pregnancy, second baby, and they went to the triage, because not in labour, come back when these criteria are met. They went in their car before they even reached home, which was only a 20-minute drive. She delivered in the car.
Yeah.
Why does that happen? And it sounds terrifying.
Yes.
It must be for everyone. What happens in those situations?
Yeah, I similarly had a friend a few weeks ago who gave birth in the shower at home, it's at home from birth. And yeah, I think this is one of those situations where a quick vaginal delivery can sound great to anyone, say, "Oh, well done," you had it, but actually can be a really traumatic experience because you don't have that sense of control. So I think it's another situation where we probably are made out to be a bit like the enemy, because as doctors and midwives and nurses, we can get it wrong. Someone comes in, birth baby, they are having contractions every 5 minutes or every 10 minutes, and actually you have an examination, you're 1 centimeter dilated, or your cervix is completely closed, for example, and you're told, later starting, but it's not quite there yet. Go home, get some rest, and come back later. And the problem is, we cannot predict who is going to go then ramp up in the next half an hour, because they've already started having contractions, spontaneous labor has begun. They're going to ramp up, or they're going to go like the majority of first-time parents and the first-time mothers and have a very slow progress, and the contractions every 10 minutes. And they stop completely for a while, and they start up again, and they're every 5 minutes, and they're every 3 minutes, and it's another 8 hours before anything happens. So we are not very good at predicting who will and won't accelerate like that. So unfortunately, that's what happens. We only have the tools at our fingertips. So when you come in to be assessed, and the first thing I would always say to do, if you think you're in labor, it's phone. We're quite good at assessing people over the phone. In the sense, we're not necessarily looking at what they're saying, but how are you talking? So I remember I got my husband, even when I thought I was in there, just phone first, and they asked to speak to me. And then they don't want to speak to me. Okay, maybe it's partly a privacy reason, but I was like, yeah, you can speak to them. But it's also to hear your breathing. How are you talking? Are you able to complete a sentence?
So interesting.
And I think, if you're on the phone and you're like, yeah, everything's fine, and my contractions started, and they're every 20 minutes, I'll say, okay, you're doing really well, stay at home for a bit longer. So you don't waste that journey into the hospital. But if you're struggling to breathe through them, and whilst you're on the phone, you have a contraction, and then you see, you're not even able to carry on talking because we're not much tone, it's probably a good time to go to the hospital. So you want to try and kind of, when you go in, so you don't get turned away. So you want to try and ideally go in there when you're around 4 to 5 centimeters is ideal. So you should be having your contractions every 2 minutes, and that they've been going on for over an hour. If it's your first baby, that's a good time to go into the hospital. But if you need pain relief, if you think something's not right, if your baby's not moving well, you should be going in soon. Sometimes you just need to trust your gut. So if you go in and they're like, yeah, you're 1-2 centimeters, not happening, go home. But you're like, I know that I'm not that dilated, but it's really strong. Maybe don't go all the way home. Go for a little walk around the car park and just sort of stay around, hang around and see. So it might be their way of saying that we're not going to make a bed for you. We're not going to put you on the labour ward, because you could be there for another 24, 48 hours before things really get going. But you could also have your baby in the next 2 hours. We don't know.
Okay, fair. I think there's, we've talked about the pros and cons of home births, car births, labour ward births. I think that one thing I found is that there's this misconception in the public that because childbirth is natural, that it's risk-free.
Yeah.
So I think it just plays on that idea that everyone has their own expectations of what they expect their pregnancy to be. And I don't think that there's enough knowledge about how often things go, not badly, but straight from the plan.
Yeah, I think that's why when we are thinking about antenatal education, which I want everyone to have access to high quality antenatal education so that we can do that. So we can think about what might labour look like, and what, when I talk about when labour begins, what it might look like, I'm not saying it's just going to start and then you're going to have these many contractions and then it's going to go to this and then you'll come in and then you'll push your baby out. And I explained that it can be a start-stop process. So that's why I started making YouTube videos, for example, and I talk about, am I in labour? I've got a video about that. And I literally am talking about how difficult it is to know.
You might great to start those 2 antenatal series.
That's exactly there for that, because you might see your show, and does that mean I'm in labour? Does it not? It might mean you're going to start babies later. It might mean nothing at all. People tell you your baby's dropped. Does that mean you're going to give birth next week? Is your bum's dropped, or does it not? There's so many things that.
What does that mean? Sorry.
Yeah, so it's called lightening. Some people talk about, and that means your baby's been sitting up here, and suddenly you see your mum, and they say, "Oh, mum's dropped down." It can mean that baby's engaged, but it also may mean nothing at all. So for some people, it is the first step. and the baby drops down, lowering the pelvis, puts more pressure, they see their show, and then they start to have some contractions and they go into labor. But especially if it's not your first birth, it's not very large.
Because even if the baby, what if the baby moves, like let's say changes position?
Yeah.
Would that also lead to a change in the bar?
Yes, although towards the end, babies tend to shift their whole position. There's not as much space, so then more likely just for their heads to kind of, they do shift and their head is able to drop lower down.
Fine.
But yeah, so these are all good reasons why I think our antenatal education shouldn't just cover the kind of straightforward and expected plan, and that we think about all the different ways that labour might present itself so that you can be prepared for any of those eventualities.
Because there's so much nuance. Like with everything, with all of the videos that we make, there's so much nuance involved. It can often be difficult to express all of that within a 60-second video.
I think it's one of the things that are like millennial and Gen Z brains aren't very good at comprehending is that, in this life we live at the moment, these are predictable. You decide you want to watch something, you don't even have to wait till Thursday for that TV program to come on, you can turn on Netflix, you watch it. You want to have a question in your head, you can look it up and get an answer straight away. It's with, we're used to the internet, we're used to having everything kind of go as expected. Mm-hmm. And the thing about pregnancy and birth is there is no as expected. A third of people have a cesarean. I can tell you, it's not in a third of people's plan to have a cesarean, but that is what happens in the end. And so you don't necessarily know which category you're going to fall into. And that's why I think is the best way of having an empowering and positive experience is just by acknowledging all of this. So that you don't have disappointment and just say, look, I don't know how these things are going to turn out. I don't know I can think about what's in my control and what's outside of my control, and think and concentrate on the things that you can change or that you can affect.
Fair enough. I didn't realize that a third of pregnancies end in cesarean sections. You always see these articles in the papers every, I don't know, it's cyclical every couple of years, right, where they start talking about people being too posh to push. Even now, do you notice that the rates of C-sections changes depending on the area where you've worked? And also, have the rates increased since you first became a doctor?
So really good question, because as I said, a third of pregnancies end in cesarean, and that actually is all of cesareans. So it was probably more like about 25% are cesarean sections that happen at some point in labour, and the rest are planned cesareans. But again, those people haven't necessarily requested a cesarean. It might be recommended because they need breech, or because they've got a twin or triplet pregnancy, or whatever reason that they have a planned cesarean, but it may not have been within their plan initially. Yes, I've absolutely recognised that it's quite area dependent. I worked at a hospital where the C-section rate was 55%. So over half of people ended up with a cesarean section. That hospital deals with particularly complex pregnancies, particularly complex neonatal conditions and maternal conditions as well. So sometimes the cesarean section is recommended for the well-being of either baby or mum. So it's not necessarily to say how they manage labour is so different, but some areas it is, and there'll be areas where, yes, people might come in requesting a cesarean in more often than others. And I don't always see it as a bad thing for someone to come in, an area where people are coming in requesting cesarean. I don't think it means they're too push to push. It might just, we have to kind of pull it back and say, why are these people asking? And it's an opportunity to have a really good conversation. Why are you asking for a cesarean section? Is it because you're scared of contractions? Is it because you have, had someone really close to you have a really, really traumatic experience that you don't want to go through? Is it because you've had, multiple operations on your tummy and you just feel like it would be better for you to have a cesarean? We can think in your individual circumstances why having a cesarean is best for you. But some people do choose that, there is no real reason, that they just feel more comfortable with the cesarean section. And as long as you have an opportunity to have a conversation about what the risks are, you have the right to choose. Well, at least in the UK. I don't know how it works in other countries, but in the UK, if you want to have a cesarean, you do need to go to that appointment where we talk about the risks and benefits of a cesarean, but you can choose to have that.
Okay. That's good. I wasn't fully aware of that anyone can just choose to. I thought it was all, as with a lot of the other things in NHS, stratified on risk.
So it used to be part of like the numbers that hospitals were trying to reduce their C-section rates. But after the Ockham report and some other recent reports saying that practice is dangerous. It's dangerous for doctor to try and tell you that you shouldn't have a cesarean section if you feel that that's the right thing for you. Because if their mindset is about reducing the number of cesarean births, we might be accidentally overlooking or kind of underplaying some conditions. So what we should actually be doing is saying, so some people will naturally want a cesarean, but we just shouldn't have it in our minds that we need to reduce how many cesareans we're doing, and just go on a case-by-case basis.
So moving back to vaginal births, I've had friends and patients who have had tears during delivery or even episiotomies. They get sutured up, then they come and see us a week later because it looks infected. The wound is opening. They've had antibiotics in triage. Sometimes I've just extended the course of antibiotics and asked them to get back in touch with maternity triage, because ultimately that's who needs to see them. But we never reclose the wound. What ends up happening? Because I've not actually yet managed to follow those patients through yet.
Yeah, so it's really common to tear during delivery. But I think over 95% of people who have a vaginal birth will have some form of tear. So that might be a first-degree tear that's very superficial, a second-degree tear. They might have an episiotomy, so a cut made, or they might have more severe tear, like a third or fourth-degree tear. Tears are very common. Sometimes we use stitches to close them. And like you say, it's quite common that those stitches might pop open. Doesn't always mean there is an infection, but often there is a superficial infection or some reason why that tissue opened up again. So you should definitely, if you're worried about your wound, take a mirror, have a look yourself. If you're having a home visit from a midwife, ask them to have a look as well. But if you think that the wound is open, or if you're feeling more pain, go and see the doctor or get someone to have a look. But yes, if it has opened, we don't usually restitch the wound. And the reason we don't restitch the wound is especially because if there is an infection there, that infection will worsen. So you will either cut the tissues and they're going to kind of you're not really getting a nice clean edge because it's all infected tissue that's going to fray. So it's friable tissue. It tends to pop open again in any way. Plus you'd be closing the infection in, whereas that infection needs to kind of come out and be fully treated. What eventually happens is it heals by secondary intention. So that means that instead of when we close a wound, we're trying to stick the edges together. That's primary intention. But actually what happens if the edges stay apart, it heals from the bottom up. So that wound is eventually closed because you basically make more tissue in that space.
Perfect. Okay, that makes sense. And if that happens, should people just go straight to triage, or would you recommend that they see their GP first?
It will slightly depend on what country you're coming from and what the setup is. In the UK, most maternity triage will be happy to continue to see you up until either 6 or 8 weeks after birth. So you can go see them without an appointment and you'll just go back to the assessment units. Or you can see your GP. Either is the same because the treatment is going to be the same. It's some antibiotics. We might do a swab just to confirm the body is sensitive to the antibiotics, but the treatment will roughly be the same. In other countries, you might be going back to your gynecologist or to your obstetrician, so it will just it's where you are.
Perfect. Thank you so much. That was absolutely spectacular. Thank you.
Brilliant. Thank you.